Forensic nurse examiners take care of victims of violent crime, but we do that using, first and foremost, we are registered nurses, and we add on our expertise of all the years that we do prior to becoming forensic nurses. And we have education on topics such as forensic photography, evidence collection, neurobiology of trauma, and other things, and a court testimony. And then we take those and we take care of the patient, but we also learn how to do it in a trauma informed, patient centered way. So we're dealing with the trauma secondary to the patient. We want to take care of the patient first and not the trauma. In addition to their medical and their forensic needs, we also set up any resources or referrals that they might need: advocacy, law enforcement, mental health services, anything of that nature after the fact. So we will start out, when we first start the program, we'll be doing sexual assault, sexual abuse of all ages, adult, adolescents, and pediatrics. And then we will evolve into taking care of patients of domestic violence and human trafficking. And then we will go a step further into taking care of elder abuse and neglect patients, as well as the non-accidental traumatic injuries such as gunshot wounds, stabbings, and physical assaults. The FNE program is getting ready to launch. We have most of our processes in place, our policies. We've worked with our collaborating agencies in the community, and we have a great set of nurses who have come on board. Several of us are experienced, so we'll be precepting the new nurses that are coming on board with us. So once we do start, we'll have 24/7, 365 coverage for our communities. Education and awareness and prevention all go hand in hand. And to do that, we need to do it in a 3-step or in 3 different phases. So we do primary, secondary, and tertiary prevention. So the primary would be collaborating with our local community agencies, law enforcement, the CACs, other advocates, to create educational opportunities for the community and for also their organizations and their programs. We need to find out where our deficiencies lie in terms of educating, create those programs, and then get them out into the communities. In terms of secondary prevention, that would be the forensic exam itself and having the patients come in. And we need to make sure that we're giving that patient-centered, trauma-informed care to them. We also need to make sure that our FNEs are maintain their competency through education. And we also need to make sure that our patients understand that they can come to us at any time, 24/7, and that we are giving them the care that they need based on the circumstances of why they're coming to us. And then for tertiary care, that would be anytime or anything after the fact. Can we help change legislation to help better serve our victims? Can we do research to find more evidence-based practice to better serve our patients? So those are the three levels, if you will, of prevention that we want to look at and make sure that we're maintaining to help better serve our patients that come in. Well, they'll start if they present to the ER, they will first be triaged by the emergency room staff. At that time, the forensic nurse examiner and an advocate will be called in. And while we're in transit, the patient will be medically cleared by an ED physician, and anything that's medical always takes precedence over any type of forensic exam and what it is we can do for the patient. So once they're medically cleared, we will take them to a private area that's our own interview and exam rooms. It's outside the ER, it's quiet, it's private. We will start our exam first by just asking a few basic questions, trying to get an idea of what it is that has happened. And then we will give them their options. And then based off what they decide is best for them, then we may or may not continue with the exam. Then once we start the exam, and that includes, sometimes it includes photographic documentation, it includes collecting swabs, things of that nature, maybe collecting their clothes. Once we're done, then we will continue with discharge education and making the referrals. And if any time during the exam we might find a reason, such as an injury, to bring them back for a follow-up exam, a follow-up forensic exam, then that will also be scheduled at that time. There's several things we would like to contribute, but the two main ones, I think, first and foremost, we want to let the community know that we're there. The PD region has not had a forensic nursing program before, so they haven't had these services. So we want to make sure that they understand that we are here for them. We know that a lot of um, assaults and abuse cases go unreported, and that's because people are scared. They think people won't believe them. They don't know where to go. They don't know where the services are. They don't know that there's help out there. So we want to make sure that they understand that that help is there for them, and that if they come and see us, they're going to be safe. Their confidentiality will be maintained. We will take care of them. We will believe them, and in that way we can help them on their road to healing and getting and getting some help in their referrals or whatever it is they may need. And then second, I think as forensic nurses, we have a responsibility to help those within the state help make better legislation for those victims. What expertise can we bring to the table to help them make the decisions that are needed to make better options or better care for these patients to take care of them. I think it's important to know that victims of crime or the ones we see are not going to just be females. When people think of sexual assault, they think of domestic violence, they automatically think females. But we know that males are also victims. And so we are there for them, and we will see them all. And in addition to that, the LGBTQ plus community is a very highly targeted community. And so we want to make sure that they understand they can also come to us for unbiased, that trauma informed, patient centered care and very non judgmental. And they can come in and we will do whatever it is, because we are actually trained in also how to care for that population, and not just from the way we address it, but also from a physical standpoint. Sometimes with the transgender community, there's actually ways that we change our exams just for those patients. So we want to make sure that they understand that they too can seek our help. We also want patients to know that the majority of them, if they don't want to report to law enforcement, they don't have to. You can still come in and have a forensic exam. You can still have everything that goes with it, and you do not have to report. So some people think that I can't seek help because I have to get law enforcement involved, and that's not true. So we're there first and foremost, like we said before, for the patient, and not for the trauma itself. And we will support any decision that you make, that's made that you want to make yourself and is the best for you. Well, because every situation is so different. A patient might be brought in by law enforcement, and that's how they're notified. A patient may come in on their own accord and write down that they have been assaulted or a victim of some type of assault or abuse. Sometimes they might just have a chief complaint, a very generic one that says arm pain. But once they get into triage and they really start talking to the nurse or the triage nurse, sometimes that comes out, sometimes it doesn't. So the majority of the time, the staff is going to know, and they're going to know to contact us. On those off chances that they don't, and sometimes it might take until the patient's admitted to the hospital, and sometimes it's determined up there or it's disclosed up there. Every situation is different, but those are the ones that will go in and will train the ER. If this happens, you do this. If this happens, you do this. So I think we have all of our different scenarios down, that we have a plan for each one. So the SART teams are definitely a form of primary prevention, because it's those support groups. It's a team, that will be building in the PD region. So it's a sexual assault response team. And we'll meet monthly. We'll talk about cases. This is what worked here. This is not what worked here. Okay, but now we need to change the way we respond to something. So it's a multidisciplinary team where we bring everybody on board. So it'd be the forensic nurses, law enforcement, maybe the solicitor's office, the advocacy group, anybody who's involved in that care of that patient at that time, at that acute time, we'll bring on board and just go over things and figure out, are we doing the best we can for these patients?